Pulmonary embolism is a clot obstructing flow in the pulmonary artery. It is usually due to a DVT breaking off and traveling to the pulmonary vasculature. I think that we are all pretty familiar with the big risk factors for PE. Here they are for your viewing pleasure. Hallmark signs are shortness of breath, chest pain, often described as sharp or pinpoint. However, those are neither sensitive nor specific. And of course, tachycardia. If you have a patient with persistent unexplained tachycardia, PE should be pretty up there on your list of differentials. Let's talk about the respiratory problems caused by PE. The issue is VQ mismatch. The patient is breathing in perfectly good oxygen. There's nothing preventing them from taking in or expiring air. However, the clot in the pulmonary vasculature is preventing oxygen and CO2 exchange, so the patient could be breathing in all the good oxygen in the world, but they aren't able to diffuse that oxygen into the blood, so deoxygenated blood is being circulated in the arteries to the body's tissues, which then become hypoxic. This is called shunt. The bigger the PE, the bigger the shunt, and the worse the hypoxia. This is why the patient with the smaller PE may be a little short of breath, may have chest pain, but they may be oxygenating pretty well because only a little segment of the pulmonary vasculature is affected. Small PEs are definitely a deal. They aren't good for the patient, but in the grand scheme of things, patients do very well with a little bit of supplemental oxygen and heparin or Lovenox to prevent further thrombosis. These patients will probably be discharged on Eliquis or some other kind of anticoagulant therapy, and then worked up to rule out cancer, barring another obvious cause of the PE. Massive and submassive PEs are a bigger deal. Massive PE is characterized by PE symptoms with hypotension and shock. Submassive PEs are symptomatic and have systemic effects, but they don't have hypotension yet. And while hypoxia is very bad, it's usually the cardiovascular effects that will kill the patient with a massive PE. The right ventricle is a little wimp. Unlike its bigger brother, the left ventricle, the right ventricle does not contract forcefully, it's thin, and it is not muscular, and it does not accommodate stretch or stress well. As you know, the right ventricle is responsible for pumping blood into the pulmonary artery. If there's a giant clot boulder sitting in the pulmonary artery, then the right ventricle is going to push out pretty easily, trying to overcome that increased afterload. And when that happens, this is called right ventricular strain, and that will lead to not handling preload coming back to the heart from the vena cava well, and you will get myocardial ischemia and eventually a non-functioning heart. If the patient has hypotension, then that's kind of a duh thing telling you that they have right ventricular strain. But in submassive PE, how can you tell if they have RV strain? Well, you could use ultrasound, or if you're in the cath lab, you could shoot right heart or pulmonary artery pressures. But pre-hospitally, the best way to get an idea that their RV is pooped is by doing a 12-lead EKG. Keep in mind, though, that a normal 12-lead EKG does not mean that there is not RV strain. That being said, there are 12-lead changes that should make you suspect PE and PE with RV strain. I think that everyone has heard of the S1Q3T3 sign. However, that only occurs in around 10 to 50% of PEs, depending on which source you're reading. While the presence of S1Q3T3 in a symptomatic patient will definitely make you very, very suspicious of PE, it is not sensitive. The absence of S1Q3T3 means virtually nothing when it comes to ruling out a PE. Right bundle branch block in a patient with known or suspected PE is worrisome. Again, not sensitive nor specific for PE, but right bundle branch block does suggest that there is right ventricular strain. Also, T-wave inversions in the anterior leads may also suggest PE with RV strain. What about the D-dimer? Well, what about it? To use complex medical terms, D-dimer is used to indicate clotting abnormalities that are going on. Well, a lot of people don't even look at D-dimer anymore. It's okay for predictive value. If it's elevated, then you might have a PE, and if it's negative, then you might not have a PE, but it's not nearly adequate enough to rule in or rule out. These days, if there is clinical suspicion, they're going to do some kind of radiologic exam, whether it's ultrasound, CT of the chest, or a VQ scan. Let's talk about treatment of the pulmonary embolism. Airway management. You don't want to intubate these patients if you can avoid it. You don't want to give them induction meds. It's going to crash their blood pressure. And then you intubate them, start delivering positive pressure ventilation, which is going to increase intrathoracic pressure and put even more of a burden on the right ventricle, which has already checked out. That is a great way to cause life-ending hypotension in the shocked PE patient. Breathing. Oxygen helps, But remember, if it's a massive PE, there's VQ mismatch, and it might not help them that much. From years of experience of doing critical care transports of tons of patients with PEs, a non-rebreather often works quite well. High-flow nasal cannula works even better because it's washing out dead space and providing a constant high flow of heated and humidified oxygen. Less commonly, but I definitely have seen it, BiPAP or CPAP has been used, but then again, that's going to deliver positive pressure ventilation that is going to put some strain on the RV. Circulation. This is where things can get dicey. When the RV is jacked up, we automatically think about giving them preload. However, in patients with a massive PE, the right ventricle is not going to be able to handle a nice juicy fluid bolus like you would give to other patients who need preload. Too much fluid could cause the right ventricle to crap out even more. Unless absolutely necessary, try and avoid giving IV fluids. But if you need to, give a gentle, judicious bolus of IV fluids. What these patients typically need are early vasopressors, and as usual, norepinephrine is the GOAT in the shocky PE patient. It vasoconstricts to raise the blood pressure, but it also has a beta property which helps to effectuate flow through and from the heart. If the PE is massive or submassive bordering on unstable, they'll probably administer lytics, and if really bad, they'll take them to the OR and do a thrombectomy. If the patient is not getting lytics, then definitely expect to see them on a heparin infusion to prevent further thrombosis.